Hello, this is Dr. Fakir Raveri. Welcome to this presentation on travel medicine and immunizations, brought to you in collaboration with Doctors Chang and Sosin. As you can see from these stats, international tourists have exceeded 1.2 billion persons, and depending on the destination, 22 to 64% of travelers report some illness. Now, most are mild and self-limited, such as diarrhea, respiratory infection, skin disorders, etc. And some return to own countries with preventable life-threatening infections. Yet 20 to 80% of travelers do not seek pre-travel health consultations. Now, here are some examples of mosquito-borne infections. Also food and water-borne infections, other viruses, tick-borne infections, animal-borne infections, and other issues that travelers may encounter. The ones that are bold are actually the topics that are covered in this presentation. The syringe symbol shows that there is some sort of immunization, either PO or injectable, available for these infections. Vaccination is the easiest and most successful way of preventing disease. This is an essential preventative measure for not only the health of our patients, but also to keep healthcare costs down. As a pharmacist, you will not only be administering vaccines, you will also be responsible for detecting gaps in vaccine records and recommending appropriate action. In general, there are two types of vaccines: live attenuated vaccines and inactivated vaccines. Live attenuated vaccines are modified from the virus or bacteria. These vaccines must replicate to be effective, and they need special handling to keep them alive. Whereas inactivated vaccines are composed of all or a fraction of virus or bacterium. Virus or bacteria is inactivated using heat and or chemicals. Now here's a list of different vaccines by whether they are live attenuated vaccines or inactivated vaccines. Here are some reliable resources. So in general, you can use the CDC's website, which has excellent tools for immunization, including immunization schedules that you can get for free. Also, you can use the World Health Organization, especially for immunizations that involve travel medicine and those that are not available in the United States, but may be available outside of the U.S. when patients or anyone is traveling internationally. Another tool, which I will talk about later, is this interactive graphic from New England Journal of Medicine, and I'll go over this. You can click on these links. And also, the Immunization Action Coalition is an excellent free tool with a lot of information, a lot of PDFs, including vaccine information schedules that are available to to anyone. The first learning objective is recommend appropriate primary prophylaxis measures for a patient at your outpatient pharmacy traveling to an area where mosquito-transmitted viruses are endemic. Now, these are mosquito-transmitted viruses. So the most recent one is the Zika virus, which is a single-strand RNA positive sense virus. It's primarily transmitted by Aedes aegypti and also Aedes albopictus, which are two species of mosquito. So these two species of mosquito are like the most common one. I can see that other viruses, including chikungunya and dengue and yellow fever, are also transmitted by these two species of mosquitoes. They are known for biting during the daytime. So there is no risk overnight when people are sleeping from these two species. Now, Zika specifically is also transmitted vertically from mother to child. There are also reports of sexual transmission, as well as transmission through transfusion, as well as organ transplantation. Now, the incubation period for Zika virus is about 3 to 12 days. That means once someone is exposed to Zika virus, it takes 3 to 12 days before they have symptoms. Now, outside of incubation period, I have also listed how long the virus stays around, for example, in the blood. So in the blood, the virus will stay for 3 to 5 days. So this is important to know, because if you are to diagnose the patient, you only have 3 to 5 day window to detect it in the blood. Now, more recently, we have found that it actually stays around longer in the urine. So urine tests are actually more ideal, because you have a larger window for diagnosing it. So 10 to 20 days. Now, in the semen, the Zika virus is reported to stay for several weeks. Latest reports suggest that it may actually stay in the semen for longer than 2 months. So that's important to know, if you are to make recommendations to patients, and if someone has been exposed to the Zika and they want to plan pregnancy, then you want to advise them to delay their plans by at least 6 months, just to be sure. Now, chikungunya, also transmitted by these two mosquitoes, and incubation period is about 3 days. And we don't really have vaccines available right now, primarily because lack of interest and funding. There are vaccines in development for Zika virus. The next virus is the dengue virus, with the incubation period of 5 to 7 days. There is one vaccine available for dengue outside of the United States. So this is available in Brazil, the Philippines, and Mexico, but not in the United States. So if patients are traveling to those areas, they can actually get the vaccine over there. Now, for yellow fever, the two Aedes species of mosquito will transmit, as well as the Hemagogous species of the mosquitoes, which also bite during the daytime. We do have a vaccine available for yellow fever. It's called the yellow fever vax, and I will talk more about that later. Last, we have Japanese encephalitis virus, which is actually transmitted by the Culex species of mosquitoes, which bites at nighttime. Incubation period is 5 to 15 days, and we do have a vaccine available for Japanese encephalitis virus, called the Ixiaro. Now, here are the two most common Aedes species of mosquitoes. Now, in the United States, you can see that these mosquitoes are common in the south regions of the United States. More commonly in Florida is known for being the Zika zone, as well as Texas and southern regions of California. And then worldwide, of course, south regions of the US, as well as Central America and South America, as well as a large portion of Africa and Far East Asia. These are where the Zika virus is endemic. Now, when you compare the symptoms of chikungunya, Zika, and dengue, because these viruses are pretty much related through evolution to each other, including sharing the vector for transmission. One thing that stands out is that when it comes to thrombocytopenia, note that dengue is actually known for high intensity thrombocytopenia. So it's important to know, because these are pretty much, this is called the dengue fever. Zika will cause fever, chikungunya will cause fever. So one of the things that patients will need is treatment for fever. So for dengue specifically, it's important to avoid aspirin and NSAIDs because of the risk of bleeding due to this high intensity thrombocytopenia caused by the virus itself. Now, Zika and pregnancy. Infection during pregnancy, and the latest data suggests it can be at any trimester, can cause birth defects called macrocephaly. So you can see in this picture, this is a normal size of the head in a newborn, And then you can see through microcephaly there will be growth retardation of the brain and the head. So this is an actual picture of a baby that was born with a microcephaly associated with Zika infection. Now, among all these viruses that I mentioned so far, Zika is the only one that is actually known to be teratogenic. Now, let's look at the management of these infections. So for the Zika, there is no specific treatment. Treatment will primarily be supportive care, hydration. It is important to use APAP for fever and avoid aspirin and NSAIDs if Zika has not been confirmed, because presentation could be just like the dengue virus. So if you don't know for sure if it's Zika virus, you should avoid aspirin and NSAID because it could potentially be dengue. So you don't want to risk bleeding in the patient. Antihistamines for cutaneous symptoms, and of course rest. As far as prevention, it is important to postpone pregnancy by at least 6 months. It's actually suggested to delay by 2 years, which can be difficult, but definitely at least 6 months. And it goes back to what I mentioned about the virus lasting in the semen for probably more than 2 months. So it would be safe to postpone pregnancy by at least 6 months after exposure or potential exposure. Other things that can help with prevention is using air conditioning, screens or nets, wearing long sleeves and pants, permethrin treated clothing, insect repellents, eliminate standing water containers, and use condoms, since it is also sexually transmitted. For chikungunya, also no specific treatment. Supportive care is recommended. For the fever, NSAIDs can be used in chikungunya because we don't have the risk of bleeding. No specific vaccine. So as far as prevention, basically avoid exposure, including many of the measures for preventing Zika virus. Applies to chikungunya as well. For dengue fever, no specific treatment. This is extremely important to use APAP for fever and avoid aspirin and NSAIDs, as I mentioned. And no specific vaccine in the United States. There is a vaccine outside of the US that could potentially be used. So best thing for prevention is to avoid exposure, including many of the measures that I mentioned for Zika virus. Now for yellow fever, also no specific treatment. We do have the yellow fever vax, which should be given at least 10 days prior to travel to a yellow fever endemic region. It is a live attenuated vaccine. It's a single dose. Patients can experience local site reactions. And because yellow fever vaccine is made in the egg, it's important to assess the patient for eggs allergy, as well as gelatin allergy and latex, because there is some component of latex in the vaccine. Now, Japanese encephalitis virus, also no specific treatment. We do have a vaccine available that should be given at least 7 days prior to travel to a Japanese encephalitis endemic region. It is an inactivated vaccine. It is a 2-dose series given 28 days apart. So the second one should be given at least 7 days prior to travel. So you can imagine 28 days before the 7 days would be the first dose. Now, it's only recommended if someone is traveling to a Japanese encephalitis endemic region and they're planning to stay for at least 1 month. So if they are to stay for less than 1 month in that area, it's not recommended to use the vaccine. Now let's take a look at this interactive graphic. Now when you click this link, it will bring you to this article called Medication Consideration Before International Travel, published in New England Journal of Medicine. And if you look over here, there's the interactive graphic. If you click it, it will open this, and you have different tabs, and one of them is geographic disease distribution. So here's a map of the world, and then you can choose which which infection you're interested in. So for example, chikungunya, if you click on chikungunya, you can see what areas are endemic for chikungunya. You can also zoom in and out. You can also click, for example, the Japanese encephalitis, or you can unclick chikungunya. So here's the areas where Japanese encephalitis is endemic. Let's see what else. Yellow fever, here's where the yellow fever is endemic. And last but not least is the Zika virus. So this is an excellent tool that you can use, which is available for free. Alright, so when it comes to insect repellents, we have several options available. Note that all of these options are safe for use during pregnancy, and also if there is concern for animals, DEET is also been reported to be used safely in dogs. DEET can repel mosquitoes and ticks. Now, concentrations greater than 50% does not improve efficacy. And as far as repelling ticks, at least 20% concentration is required. One of the things about DEET is that it can damage clothes, including synthetic fibers, and it can also damage plastics on eyeglass frames and watch crystals. Now, picaridin also repels mosquitoes and ticks. A concentration of 19.2% is as effective as long-acting 33% DEET. It is odorless and non-greasy. DEET can be greasy, so that's something that patients may complain about. So if they do, you can switch to picaridin, which is non-greasy. It does not damage fabric or plastic, and it can discolor leather and vinyls. We also have other options that are really not as effective, but the last option that's pretty effective is permethrin, which can repel mosquitoes and ticks and also kill them. So this is something that we use on clothing, mosquito nets, tents, and sleeping bags. So it's basically you treat these items using permethrin. Now, permethrin remains active for several weeks through multiple laundry sessions. So that's good. It should not be applied directly to skin, so it only treats clothing or other items, but do not apply it to skin. Pre-treated backpacks, boots, and sleeping bags 24 to 48 hours in advance and allow to dry. So before traveling, at least allow 24 to 48 hours. And then you also need to retreat using permethrin according to the label instructions. So the bottom line is that wearing protective clothing treated with the insecticide permethrin, in addition to using DEET or picaridin on exposed skin, may provide the best protection. Now, when it comes to providing patient counseling, here are a few points. So one is that the agent's duration of action and need for reapplication is important to be discussed with the patient. Application of sunscreen 15 minutes before the repellent if needed, and sunscreen repellent combination should be avoided. So it's recommended do not use products that have combination of these with a sunscreen. The third item is give instructions to spray the product in the palm of the hand and then apply it to the face. The importance of not applying repellents to skin beneath clothing, so only apply to naked skin. Because if you apply it to the skin under clothing, it can cause irritation. Awareness of the product's expiration date is very important. And also caution with use in young children. So just follow the package labeling when it comes to using it in children. And last is damage of plastic and fabric by some products. That's important to be discussed with the patient. Now here are some specific brands of these, including how long it. So in general, the higher the concentration, the longer it lasts. Also, there are some costs um, reported here in this table. Let's see. Alright, the next learning objective is given a patient traveling abroad, identify causative organisms, symptoms, prevention, and treatment of food or waterborne infections. So in general, there are three common infections that could be due to food or waterborne infection: hepatitis A, cholera, and typhoid fever. For hepatitis A, we do have vaccines available. There is also one vaccine available in the United States that's a live attenuated cholera vaccine, and it should be given at least 10 days prior to travel to a cholera endemic region. Again, you can use that interactive graphic to see what areas are endemic for cholera and also for hepatitis A and typhoid fever. We do have two vaccines available for typhoid fever. So one is an oral live attenuated vaccine, and the other one is a intramuscular injection, which is a killed vaccine. So the typhoid fever is caused by bacterium Salmonella typhi. An estimated 5,700 cases occur each year in the US. Both ill persons and carriers shared Salmonella typhi in their stool. Stool sample is needed for definitive diagnosis. Symptoms include fever, weakness, stomach pain, headache, loss of appetite, and rash of flat rose-colored spots, like you can see in this picture. And here are the two vaccines that I mentioned. The next learning objective is given a patient at your outpatient pharmacy getting ready to travel to Colorado to climb Mount Elbert. Identify prophylaxis measures and treatment for high altitude sickness. Now, one thing about Mount Elbert is that the elevation is over 14,000 feet, which is equivalent to 4,400 meters. So what exactly happens at high altitudes? So high altitude illness, there are three different kinds: the acute mountain sickness, the high altitude cerebral edema, and the high altitude pulmonary edema. So these happen like in order, and they also get more severe. So high altitude pulmonary edema is a lot more severe than just the acute mountain sickness. So in this picture, you can see that in the alveoli, that's where the oxygen exchange occurs, and this basically works based on normal oxygen levels. What happens at high altitudes, so for example at an altitude of 4,300 meters, the partial pressure of oxygen is a lot lower than at sea level. So because the normal lung function is based on normal oxygen levels, at higher altitudes, the lung basically will not be able to have enough oxygen. So what does that mean? So first of all, this will depend on several factors. So the terminal altitude, so the higher the altitude, the more severe that the high altitude illness is. Also the rate of ascent. So if you ascend very quickly, the body cannot compensate for the drop in oxygen pressures. So that would cause more severe high altitude sickness. The time spent at maximum altitude. So it's recommended to not spend, once you get to the highest altitude, just don't stay there for too long. Because the longer you are exposed to that low oxygen concentration, the more likely that the body will, progress into a more severe high altitude illness. And also the altitude when sleeping. So when sleeping at low oxygen levels, that can also lead to more severe high altitude illness. Now, in general, acute mountain sickness occurs in at least 25% of people who ascend rapidly to an altitude of 2,500 meters. And in most people who ascend rapidly to 2,800 meters or higher. So you can imagine at 4,300 meters, you're a lot more likely to have acute mountain sickness and potentially more severe forms of high altitude illness. Now, patients who are exposed to reduced oxygen concentration gradually are able to compensate, and this process is referred to as acclimatization. So through acclimatization, there's increase in ventilation and PaO2. There are also circulatory changes. There is hematologic changes such as increase in hemoglobin level. There's also oxygen delivery and utilization. So there's muscle atrophy, there's angiogenesis, and nitric oxide synthesis. So all these compensatory mechanisms will help prevent high altitude sickness. Now here are some risk factors for high altitude illness. In general, low risk is if someone had no prior history of altitude illness and planning ascent to less than 2,800 meters. Now taking 2 days or more to arrive at 2,500 to 3,000 meters from low altitude and ascending no more than 500 meters per day, sleeping altitude once over 2,500, and taking 1 extra day to acclimatize for every additional 1,000 meter of ascent. So these are good things because they will have low risk of high altitude illness. Moderate risk is prior history of acute mountain sickness and ascending to 2,500 to 2,800 meters in less than 2 days. Also, no history of AMS and ascending to 2,800 or higher in less than 2 days, or ascending more than 500 meters per day, increasing sleeping elevation at altitudes above 300 meters with 1 extra day for acclimatization for every additional 1,000 meter of ascent. And then high risk would be history of severe altitude illness such as high altitude cerebral edema and high altitude pulmonary edema. Also history of acute mountain sickness and ascending to 2,800 meter or higher in less than 2 days. And ascending over 3,500 meters in less than 2 days. And ascending more than 500 meters per day above 3,000 meters without extra days for acclimatization, rapid guided ascents, and also persons with medical conditions predisposing to altitude illness. So the therapy for high altitude illness is descent to a lower altitude, typically at least a 300-meter reduction in altitude, administration of oxygen, which is usually not available on the field, but if someone can make it to a center where they have oxygen, that would be ideal. Also acetazolamide, dexamethasone as an alternative to acetazolamide, and nifedipine for treatment of high altitude pulmonary edema, because nifedipine can cause vasodilation in the pulmonary veins. For prevention, it's recommended to have gradual ascent, pre-acclimatization, avoid moderate to heavy alcohol intake during the acclimatization, avoid sedative hypnotics during the acclimatization process, avoid opioids. Of course, opioids can cause respiratory depression, so that's why it's recommended to avoid opioids during ascent. Also, acetazolamide can be used to prevent high altitude illness, and dexamethasone as an alternative to acetazolamide. And here's how the acetazolamide works. It is a carbonic anhydrase inhibitor that reduces hydrogen ion secretion in the proximal renal tubules and increases renal excretion of sodium, potassium, bicarb, and water, leading to metabolic acidosis. Now, this metabolic acidosis leads to compensatory hyperventilation and increased oxygenation of the blood. Here are the side effects for acetazolamide, and here's the recommended dosage for it. If someone has allergies to sulfonamides, acetazolamide should be avoided in those patients. The next two learning objectives, objectives 4 and 5, are pretty self-explanatory, so I let you review them on your own. Our last learning objective is identify true contraindications to administering a vaccine. So anaphylactic reactions to any vaccine is a contraindication to it. Egg allergy, so yellow fever vaccine has some components of egg, so it should be avoided in patients with egg allergy. That's the current recommendation. Now, one thing that we used to say was, some flu shots also have egg components. So, a couple years ago, it was that if someone had egg allergies, giving flu shots that had egg components were contraindicated. Now, that recommendation changed last year. So the recommendation for vaccination of people with egg allergies changed for 2016-2017, and they said that people with egg allergies can receive any licensed recommended age-appropriate influenza vaccine and no longer have to be monitored for 30 minutes after receiving the vaccine. Now, people who have severe egg allergies should be vaccinated in a medical setting and be supervised by a healthcare provider who is able to recognize and manage severe allergic conditions. So but no contraindication nonetheless. Now, for patients who had encephalopathy within 7 days of previous dose, DTaP or Tdap is contraindicated. Pregnancy, of course, any live vaccine is contraindicated, including HPV and MMR. For immunocompromised patients, also live vaccines are contraindicated, and untreated active TB, also live vaccines are contraindicated. And some precautions, so mild illness with or without fever, for example, common cold. Vaccines may be administered if the provider and parent or patient deems the benefit of vaccination to outweigh the risk to a person who has a moderate or severe acute illness with or without fever. Of course, always use professional judgment when it comes to that. That concludes this presentation.